So hello and welcome to episode 10 of our podcast, Vet Wrap. Today I have with me Dr. Alasdair, who
Hi, Chris.
has an unusual distinction in Australia of being a orthopaedic specialist, or orthopaedic veterinary surgical specialist. Do you know how many there are of you around?
There are one of me in Victoria, and there are two of us in the whole of Australia. So we're a niche bunch, us two.
And us just come along today because we would like to discuss an orthopaedic topic, not surprisingly. And we're going to have a dip into luxating patellas today, which is a field that is changing in the way that we manage that particular problem. And we'd like to go through a few of those changes and just talk through where the science is currently. And also we thought we'd include a few tips for luxating patella surgery as well near the end of our discussion. As always, if you would like to reach out and let us know what you think, like us on Spotify, and also if you've got any episodes you'd like covered across our specialists, we'll almost certainly find someone who can say something sensible on the subjects that you propose. So please reach out and email us or contact us through our various Spotify and YouTube channels. So, Al, welcome.
Thank you.
We started talking about this because we felt things had changed with respect to management of luxating patellas in dogs and potentially cats as well. Would you like to sort of describe how you feel things may have changed recently for your management?
Yeah, sure. I mean, there's new techniques, there's new implants that we've got available, but I think the greatest change that I've seen over my career has been our understanding of the knowledge of how it works. Chris, you and I are same era. You've got a few grey hairs there. I've got almost no hair now. And but back in the day when we were at vet school, we were told it was a relatively simple condition. You could grade patellar luxation in a 1 to 4, so 1 being pretty mild and 4 being patella completely luxated, dislocated, and we can't reduce it. And we had, 4 things that we could do. We could deepen the trochlear groove. We could move the tibial tuberosity transposition. We can loosen the soft tissues. We can tighten the soft tissues. And, if they were more severe, you would do all of them. And if they were less severe, you may pick 1 or 2. The reality is that approach actually still works for a number of dogs. But over the years, we've sort of recognized that there's quite a high relaxation rate. Some of these dogs they continue to dislocate, and there must have been something that we were missing in the process. And probably for me, the sort of when we started to see the big change was in the mid-2000s, and we started looking much more closely at limb alignment, and I think that's been a kind of game changer in terms of our understanding of the condition.
Yeah, absolutely. So, we were seeing reports of sort of 5 to 20, sort of roughly, recurrence of luxating patellas, and the suggestion may be that that's not entirely associated with how that individual surgeon has performed the surgery. It's not a mistake in surgery. It's potentially that we haven't appreciated the anatomical abnormality.
Yeah, absolutely. I mean, I always say to clients, though, that the problem with this condition is there's a lot of intra-op decision-making, and you're doing this in a dog that's anaesthetized with no muscle tone, and we don't know exactly what their muscles are going to do, how they're going to contract when they wake up. So even if you do it perfectly, if there is a perfect surgery, they can still luxate. But the big thing, I think, was in the mid-2000s, started initially looking at the femur and looking at femoral varus being that internal twisting of the distal femur. And was that a reason why some of these dogs were continuing to luxate? Now, the problem has always been that the femur is a very hard bone to assess angles on. And that understanding coincided with much more widespread access to CT. And we started to realize that we could accurately measure these angles, and actually the reason why some of these dogs were dislocating was this femoral varus distal bending of the femur. And we started doing femoral osteotomies, just straightening the femur. When I started doing those, it was a bit like when TPLOs first came out. You feel like it's like a sledgehammer to crack a nut. I'm taking a saw to a dog's femur to deal with a patella luxation. Am I mad?
Yes.
But actually, you do it and you realize, oh no, now it has a beautifully straight leg. Mechanically, it works well. It's a really robust fixation. And so that was probably the first change.
The first one. And from the point of view of a GP vet wanting to have a look at whether or not they may have a patient that is potentially tracking down that line. There's obviously some papers that suggest that typically grade 4 dogs may well have some degree of femoral varus, particularly in small dogs. But it's not always high grade luxating patellas across every kind of little to large, is it? It can be, you could have a grade 2 or 3 Labrador that has quite a degree of femoral varus that may need addressing in that. So is there any way we can sort of look at, from a GP's point of view, go, oh, this dog might be potentially one of those candidates, or?
Absolutely. I mean, I think you and I both agree that the smaller dogs are more likely to be easier. You probably get away with more in a smaller dog that you wouldn't get away with in a bigger dog. There's also just the difficulty of imaging. So I think in a smaller dog, you're more likely to be able to get a straight radiograph. They get progressively harder in a bigger dog. There's been some quite recent work that was very useful for GPs, though. And the basic idea is if you can get a beautifully straight X-ray and it looks straight, it is straight.
Can you define look straight?
Yeah, so we're looking for, the normal dog has a femoral varus, so an angle on the medial side of, if you're going to measure the inside angle, it's about 84 to 82 degrees, or 4 to 8 degrees of varus. And we sort of recognize that if there's more than 12 degrees of varus, that's the point that we should be thinking about doing a femoral osteotomy. So if you can get a nice straight X-ray and you measure that angle, the technical angle, it's the anatomic medial distal femoral angle, so someone can look that up. If you measure that angle, there's less than 12 on a radiograph, it's probably real. You probably don't need to worry about femoral osteotomy. The difficulty becomes if it's more than 12, it might not be more than 12, because once they start getting more, it can be just due to rotation of the femur. So in any dog, any small dog, any big dog, if it's more than 12, then I would always do a CT. Yeah. And there's some good work shows that if you don't CT these dogs, you may end up cutting a femur on a dog that didn't need it.
Yeah, yes, absolutely. Because it has a tendency, radiographs, to over measure, if anything.
Exactly, yeah.
I mean, you can sort of see, I know it's a podcast, but if I was going to put my elbow down towards the camera at the moment, it looks vaguely straight. And if I bend it, it still looks straight because it's basically line on. But if I do this to my elbow, all of a sudden I've got a big varus. It's gone when I change that angle. So getting the stifle straight on a radiograph to take a picture to actually analyze that, you could probably define a straight stifle if the fibelli are cutting through the cortices on each side of the femur, the condyles, and that sort of aligns the femur up reasonably well at the level of the stifle. So you can define varus at that point.
And the problem is, though, that so many of us are trained, is it straight by looking at the patella? And you want to get the patella in the middle. But of course, if it's got patella luxation, patella is not going to be straight. Yes. So how do you know if it's straight? Yes. So absolutely. And other things, just looking at the symmetry of the intercondylar knot, looking at the lesser trochanter, the whole femur, to get an idea if it's straight. But they can be really misleading. It can look straight. Yes. You CT them, like, I was way off on my measurements there. So
yes. So I mean, it's from a GP's point of view, if you look at it and it kind of looks straight, it probably is.
Yes.
And especially if that ties in with a relatively low grade patella luxation, so something that's...
Yeah, and then the converse, if you've got a grade 4, so it's patella's permanently luxated, then you're always going to get torsion or twisting of the joint. So the femur almost always looks bent, even if it's not bent. Yes. And I would argue it's almost impossible to get a straight radiograph on a grade 4 luxation.
Yeah.
You have no idea what your angles are
Agreed.
on those. So and grade 4 luxations are just a world of pain in terms of recurrence complications. So if you're GP and you're looking at which cases should you think about doing, definitely avoid grade 4s, I would say. And then the bigger dogs, they're harder to get straight radiographs. They're less forgiving in terms of complications. You're much more likely to get implant issues with bigger ones.
Yes.
And they're also less forgiving of the alignment issues. I think in the smaller dogs, we sometimes maybe could straighten the leg and we don't, and we get away with it. And
Absolutely.
you will not get away with that as much in a big dog.
I think that's the point. When we were discussing this briefly, I sort of mentioned, from my way of thinking about it is that at the moment the science around patellas feels like 1990s cruciate, where you could perhaps get away with an extracapsular repair in a small dog, but the increasing evidence suggested that maybe through the 2000s that TPLO was the way to go for larger dogs, because you actually need to correct some degree of the actual forces acting there. And the small dogs, you can just put a thing on it and it basically keeps stable and just about all right. I feel it feels like the same thing with patellas at the moment, where we're understanding with bigger dogs that it's actually important to get it right. And defining right is sometimes challenging. But so the first thing is talked about is the appreciation of femoral varus. I hope that makes sense. What else are we looking at now, Al?
Well, then there was femoral torsion. So is the distal femur off if it's a medial patellar luxation, so the kneecap going to the inside? They often have a relative external twisting of the distal femur, so the whole trochlea is too far to the outside.
Yes.
And so there are cases that I've done where they're actually relatively straight, but I've actually cut the femur to derotate the bottom, but it pulls the trochlea back in. There are X-ray techniques to assess that, but they are really difficult.
They're extremely difficult. I have tried. I've always failed.
Yeah, absolutely. I mean, I've can't say I've done that successfully. So that's really a CT measurement, and then I think we've really concentrated on the femur for the last 20 years or 15 years, but there's more and more stuff coming out now about how important the tibia is, and tibial valgus or varus may be an issue. So an angle to the inside, angle to the outside, but also twisting of the tibia. And then twisting of the bottom of the tibia, so the foot position changes. And actually, that's a real major thing in people. That often people with patella luxation, it's the twisting of the distal tibia, so their foot is pointing in the wrong direction, and so they want to turn their foot so their toes point forwards.
Yeah.
And when they do that, it makes their patella luxate. Yes. And we're starting to recognise that as an issue in dogs as well.
And I think it's most perhaps strongly seen in Dachshunds with pes varus, when you quite often get a lateral luxating patella with varus and maybe a medial with valgus, because they're trying to get their foot flat on the floor, and that has implications for where the knee is going to sit as a response to that.
Yeah. And I know you've treated a couple of those, and you've only treated the pes varus. And it's resolved the patella luxation, which is just a fantastic example of that.
Yeah,
so,
it's really it's such an obvious one as well when you sort of see them like that.
Yeah.
So an assessment of those, as we've sort of said, is challenging in a GP setting. And I keep coming back to the fact it's sort of recognising which ones might need that sort of level of assessment.
Yes.
So you would agree that it would be high grade?
Yes.
And potentially larger dogs?
Yes. And then, practicing at getting a good straight X-ray and realising that if you've done a nice job of getting a straight X-ray and it looks like there's a significant twist or bend in its femur or its tibia, that's maybe one that is more likely to reluxate.
So I think there's a tendency, because I'm very late to this sort of specialist game, as you know, and I mean, I think there's a tendency in GPs, as I probably had for a long time, you sort of take stifle x-rays for patellas because you feel like you should. Maybe even from the point of view of, I'm just ruling out a few other things and make sure there's nothing else going on. There's a major stifle effusion. It might be a partial cruciate, or, there's no anything else. But I think the message could be that what we're trying to put across is actually we're taking the stifle radiographs purposefully to examine, to see if we think there's any chance this dog has some anatomical abnormality, and start getting that.
And it's that
process,
full limb cranial view that you're going for. So you want to see the hip to the foot in one shot, which again is a lot easier in a small dog.
Yes.
But it's getting that and not compromising on your alignment. Sort of really understanding I'm charging this client money for this radiograph. I'm going to get a really nice straight image so I can accurately assess this. And
and I think, again, from the point of view of a GP in a GP setting, there is always a discussion that's going to be, so now we know that there is perhaps what we can sort of box up as the traditional surgery set for a luxating patella, which would be something to do with the tibial tuberosity, transposition. It'd be something to do with the groove and, like you say, soft tissue things as well. And like I said in the intro, I think there's probably an understanding that there are going to be some dogs that will fail with that approach, even if it's done really well.
Yeah, I mean, even before you get to that, there are some dogs that are going to, fail even if they're in the right candidate. And it's something when I'm teaching vets how to do orthopaedics, I'll say I would rather do a TPLO than a patella luxation, because a TPLO is a recipe. You follow the recipe, it's probably going to work.
Yes.
And a patella, there's just so much decision making and variation there that you can pick what you think is the right candidate, and it still luxates.
Yeah.
The best advice for GPs if you're dealing with these is just always warn the owner, reluxation is a risk. If you tell them it's a risk at the start, they'll hopefully be on side when you say, look, I told you it might happen.
Well, exactly. Yeah. And I think that's the point, isn't it? Part of the job of a surgeon, it's not about cutting. It's not even about the decision for which things you do cut. It's also about educating the owner of the dog, who's going to pay money for that service to be done, that the science is not perfect, and there is an element of risk. And one of those risks is we may do what seems to be an appropriate thing, but it may not actually work.
Yeah, but hopefully by understanding it more, that number is getting smaller and smaller. So
I mean, you don't want to be the second surgeon down the track on a patella, but it definitely happens.
Yes, yeah.
And it's not that common that it happens because the first surgery was not done appropriately. It's normally that the biomechanics have not been addressed.
But yes, or there's been some missing of an alignment issue that could trigger it. But there's always, nobody wants to cut a bone unless you have to. And I've got a dog at the moment that I've done 2 surgeries and it's still got a luxation, and I've straightened its femur and now I'm going to have to straighten its tibia, because you think, well, I didn't think I would have to, but now I do have to. It happens to everyone. So.
But crucially, the owner is still with you in that department because you've had the discussions along the way and
absolutely
through the thought process.
Exactly.
So I did mention very briefly that there was perhaps something new for cats, and this might be an adjunct to a time to address that. There's been a few papers recently regarding luxating patella in cats, and I still don't think we have a very great idea of the best options.
No, I think they're a separate challenge, aren't they? I mean, the first thing is they're thankfully very unlikely to have a femoral problem. So they've actually got quite a straight tibia, a straight femur, which is quite nice. So you're very unlikely to have to do that. They do have a relatively small tibial tuberosity. And anecdotally, people have said, are they more likely to have fractures of their tuberosity afterwards? It's not really been proven, but I think that the issue there is because it's so small, people intuitively try and make too small a piece of bone because there's not much bone there anyway, and then it's more likely to fracture. So I think they're a bit more fiddly. Yes. And then there's issues with the width of the trochlea as well. So the cat patella is actually significantly wider relatively than in dogs, and sometimes it can be quite hard to make a groove deep enough in a cat,
or wide enough.
Yes, wind up. So yeah, wind up. Yeah, yeah, and so there are suggestions that some of these cats may need almost like partial patellectomy. So you're taking a strip out the edges of the patella so it can actually sit within the trochlear groove. So they're a nuanced thing, cats.
I've had one of those patients that actually had, in order to get any kind of stabilization of a cat's patella, I actually had to narrow the patella, and it then did sit really nicely. But there's quite a nice piece of work that shows that the cat's patella is always wider than the groove. That sort of sits on top of a little indent rather than being down inside the groove like a dog would be. And it's important to sort of appreciate that as a subtlety of cats, I guess. And yeah, they do typically have a medialized tibial tuberosity. That's their that's if they have a deformity, that's the deformity,
yes.
isn't it?
Yeah.
Typically.
Yeah.
So I think we're getting maybe dangerously close to the point when we can start discussing how we would go about talking about the traditional surgeries. So deepening the groove in some respect, and what we can do for the groove.
Yeah.
So maybe we start there because it's kind of proximal. And that's
So a bit like you, Chris, I spent 11 years as a GP, so I did an awful lot of patella surgery as a GP, and I'd always...
More like 20.
And I used to do wedge recessions for everything before I'd specialised, and I think that's where you take literally a wedge out the trochlea, and you take another slice, and the wedge drops down a little bit more. As we were discussing earlier, you can take that wedge and the little pointy bit at the bottom, you can actually trim that off. I often use a little burr to do that, and it just allows the wedge to sit a bit more deeply. And that's how I used to do pretty much all of them. But there's a few downsides with the wedge. One of them, I think, is it's harder to change inter-op. So you're kind of committed with the two angles. You do your two angles and you can take that little bit at the bottom out, but it's a lot harder to adjust. But the biggest downside is it's very good at deepening the middle of the groove, but it's not so good at opening up the trochlear groove at the proximal end. And most cases with patella luxation, if they're medial, they tend to be luxating proximally, and it's just not as good at addressing that. So
because essentially the thing that you're deepening, because it's a wedge, is getting narrower and narrower proximally.
It's like it comes to a point, doesn't it?
Essentially, eventually, it's not deepening anything. It's just providing a little trough in the middle of the groove which is existing, if that makes sense.
So there's some good work in the mid 2000s looking at rectangular block recessions, where by taking a rectangle rather than a wedge, you can open up the groove proximally much more effectively, and practically it's a lot easier to vary. So you can take a piece out, you can go, no, it's not quite deep enough, I want to deepen it a bit more here. You can choose where you're going to deepen it. So a much more subtle thing. The one thing I did find when I started doing blocks is I think they're slightly easier in bigger dogs, and as they get really small, it's fiddly. And I have had a few blocks split when I used to use an osteotome. And now we are lucky enough to have these lovely, E-pen, tiny little sagittal saws, which are lovely for doing that. And I think with those, it's very rare you would split the block compared to tapping it out with an osteotome. So before I had the E-pen, even as a specialist, in some of these much smaller dogs like that 2-3 kilo dog, I may still do a wedge because I'm worried that if I do a block, I might split it. So I think that's something for, if you don't have access to that nice tool, that would be something to do.
To still consider. I mean, it may not be gold standard, but it's safer in some cases.
I think so, in these really tiny dogs.
But I guess my approach as a clinic owner is that addressing the issue, do we have the right equipment for the job, is sometimes a stumbling block for people in practice. But a really good drill is a relatively small investment, especially when you start doing work, of this type. Because it will pay off relatively quickly. And then you're doing a much better job all around. Even I actually don't use the E-pen. I mean, it's my hand-eye coordination thing. I find it easier to look down the barrel of my Calibri and go, well, I'm happy with that shape, and that's what I do. And the actual sag saw blades are similarly thin, so you can still get in where you need to. That's just what I do. So you don't need to necessarily have the E-pen, which is essentially like a spinal drill with attachments. So it's very, very fine. But a good drill.
Yeah, and I think that's another thing. When I started doing these, people were talking about, putting in the K-wire into the tibial tuberosity by hand. And then like anything, if you're having to use effort to put an implant in, you can't control the angle as well. So having a good drill that allows you to use your brain to think about the angle and not just the effort you're putting in makes a huge difference. That pin is actually surprisingly hard to do well.
Yes.
And
we haven't reached that point yet.
No, well, I just thought it was a nice segue into tibial tuberosity.
It's a segue. I don't know if there's anything more to say about deepening the grooves.
Yeah.
Apart from with cats, you might need to narrow the patella. That's something I would definitely think carefully about.
Yeah.
But yes, I mean, I have also taken blocks out of dogs with a osteotome, memorably one where the block, it was in quite a large dog, it was quite a while ago, but it actually pinged as I completed the cut.
Oops.
And left the field of the
Which
surgical.
words did you say there, Chris? That were not appropriate for this podcast. Golly gosh.
A 5-second rule and into some sterile saline. It actually didn't get infected. It was fine. So I do think, we've been there, and a block is a challenging surgery, I think. First time out, it requires some hand-eye coordination, I think.
Yes. Yeah.
To get your head around what you're doing. But like you say, I think that when you're in and doing a block, if you're not happy with how it's sitting, you've got more options to get your sagittaur out again, maybe cut a little deeper.
Yeah, or I often
trim
use
it up and
a burr as well. And just think, it's just that little proximal bit. I'll just burr a little bit there and just drop it down at that bit.
Yeah.
So there's just a lot of subtle nuance you can do with that.
Much more flexible.
Yeah,
absolutely. So now we can segue on to the transposition. And there are a few different methods of doing this now. I think both of us still align to what I would consider a fairly traditional tibial transposition.
Yes, and there's techniques now where you're not actually putting a pin through the tibial tuberosity, you're just going next to it. I've seen enough dogs over the years that have fracture displaced their tuberosities to not be confident or happy to do that. And a tibial tuberosity fracture, a tibial tuberosity avulsion is a limb-threatening complication. So I want to get something solid in there. The point I was alluding to earlier is the mistake I think people make when doing a tuberosity transposition is going straight craniocaudally and forgetting that dished out bit in the lateral side. So you really have to think about angling medially to avoid that.
As you move the tibial tuberosity across towards the lateral side commonly, directly straight forwards hits the space between the fibula and tibia.
Exactly.
So you have to make it medial and come into that tibia there.
A lot of thought about that angle is really important.
Just before that, what's your thought process regarding where you are cutting? At what level depth are you cutting your tibia?
In terms of the exit point, or how
just how much tibia you're taking?
I don't actually have a firm number or anything. I mean, quite a thick piece. So I'm coming in from caudal to the patella tendon. So I'm well back from the patella tendon. Probably tubercle of Gerdy, if people know what that is. Just in front of the long digital extensor. That kind of depth.
Yes.
Because I think the other cases that I've seen and had to revise where the tuberosity is fractured are often people have made it too thin or small and it just breaks.
And I think that's the temptation to go, I'm not cutting much bone off the tibia. But then you're actually, what you're doing is taking a thin section of a very important structure and then intending to move that really important structure, which is under a lot of tension and load.
Absolutely.
And the more bone you've got with you as you do that, actually the safer things are, not the other way around.
Yeah, far less likely to fracture. Absolutely. And the quadriceps is what's attaching to the tibial tuberosity. It's the strongest muscle in the body. There's a massive force on that. So,
absolutely. And if you don't have a insertion of the patella tendon, you don't have a leg.
Yes. Yeah.
So you do need to protect that.
Yeah.
1 pin or 2?
Again, this is really controversial. So there's a bunch of papers on this, but my honest opinion, in smaller dogs, if I can keep the hinge intact at the bottom end, I just use one pin because I've seen a few dogs where if you put multiple pins, fracture propagates from one to the other, and the whole thing explodes.
Yeah.
So I put one pin right at the insertion point. I think that's the safest point, and
so effectively the deepest point of your cut.
Yeah, exactly. Yeah, if you go distal to the patella tendon insertion, I think you're likely to get a stress riser there and fracturing. If you go above the insertion point, you're more likely to damage the tendon with your tension band wire. So right on the point, and not making it too big. Remember, it's a tension band technique, so the strength, if you're using the tension band, comes from the tension band, not the pin.
Yes.
So, again, if you have too big a pin, it's much more likely to fracture. So a smaller pin and then a nice chunky wire to give you the strength, I think to me is the safest thing.
The safest way.
If I fracture that hinge point distally, then what happens is it becomes rotationally unstable, and then I would think I really must put a second pin in. And then as the dogs get bigger, definitely I'm thinking about a second pin, in that 10 kilo up range. But my second pin is an anti-rotation pin, and it's often smaller than the first one, and I'm tending to go distal to the so think of the main pin at the insertion point and a much smaller one distally, because if you do two at the insertion point, again, I've seen a number of dogs that have just fractured through that point.
It's almost creating an ability for the middle to merge, isn't it? Between the two, and then
and then the other thing for Bill is if you're putting two wires in and they're parallel horizontally, never ever go above the tendon insertion point, because I've seen 3 GPs that have done that over the years with a tension band. Tension band slides down the wires and cuts the patella tendon.
Yes.
That's a nightmare.
Yes.
If you make sure your pins are at the insertion point, if you're doing that.
Yeah, absolutely. And always a tension band wire for you?
Yeah, I mean when we started doing it, it was single pin, keep that hinge distally. You don't need the tension band wire. Then there was papers showing in bigger dogs far lower complications if you use a tension band. I used to get a lot of dogs with seromas because of loose pins or the pins coming out. And then when I switched to tension banding everything, it just seemed to eliminate that complication. And I think if you don't put a tension band, there must be a little bit of wobbling or something going on there, and it just seems to be much more likely to cause problems. So I think for the 5 minutes, it's much stronger, and you're far less likely to get complications. And I'm a big fan. Yeah.
And the orientation of your pin, we mentioned medial to laterally, but also there's an orientation that you can choose between sort of perpendicular to the tibial plateau, essentially, or deviating distally. If you're worried about hitting the joint or whatever. Can you comment on how you maybe orientate that pin?
Yeah, I guess there is studies now that say going relatively more horizontal is mechanically stronger, but those studies are they're not using a tension band. The ones I've seen cause more trouble are when people have stuck the pin in the joint and maybe not realizing it, or maybe they've realized it but they're too scared to take the pin out, and then you get this pain because there's a pin in the joint. So to me, the main thing is don't put the pin in the joint. So I'm aiming slightly distally. But if you go too distal, yes, mechanically it's not as strong if you do that.
Yeah. And so then we sort of said briefly soft tissue techniques. Obviously, we alluded to maybe releasing one side and tensioning the other side. I don't think there's much magic involved with that, is there?
No, I think don't rely on it. I think we all recognise now that if you're going to do one of these surgeries, you have to do something about the alignment of the leg in the vast majority of cases, or it's going to fail. So it's an adjunct, and you can cause problems with it. You can if you're doing excessive medial releasing incision, you can give it a lateral luxation, and I always do the trochleoplasty first, then I do the tibial tuberosity transposition. I'm looking at the leg in front of me going, yep, that's straight. It's tracking nicely. And then I'm looking at, well, how much tension is there? Particularly medially, sometimes you can put your finger on that medial side, you can feel that fascia really tight. You're like, I need to release that, but don't overdo it.
Don't overdo it.
Yeah,
absolutely. Yeah. I totally agree, because I think it's very easy to create a lateral luxating patella.
Yeah,
in those cases, especially in small dogs.
Yes, yeah.
And what about, I mean, this is sort of an old discussion in some ways, but the discussion between whether or not, does every groove need to be deepened? Is it, well, you should, because if it goes wrong, at least you've done everything you can? Or do you believe there's actually a scientific reason that we should be doing every time some sort of trochleoplasty?
I mean, I think one of the frustrating things I find with this condition is how the dogs are afterwards. I think there's a real variation in what that dog looks like 2-3 weeks down the line. And some of them are amazing, and some of them are hopping on the leg for 6 months afterwards, even when the patella is not luxating. And I think that variation is the trochleoplasty, that some dogs just feel it more.
Absolutely.
And I think that we know they're going to get some osteoarthritis in there. So I think there's always a temptation of, could you get away with not doing it? And I do occasionally just do a tibial tuberosity transposition if I look at that groove and go, it actually looks really nice. I don't want to take a sort of that. But I'm always doing it with, am I going to regret this? Is this going to come back and haunt me in 3 weeks? Like, why didn't I do it at the start? Yeah. That's the dilemma. I mean, they talk about, the depth being, half the height of the patella, don't they? And so you having to look at it and going, does it look right? I think there's a risk of overdoing it as well. If you make this really deep canyon in the middle, the patella edges might sit in the ridges, and the center of it's not even hitting the bottom because it's so deep. So I think you have to look at them and make a good assessment. I mean, if we have the luxury, we've CT'd them, sometimes you can tell from that as well. I think the harder thing with those are, some of them you go in and they're really chronic and they've this gnarly, knobbly, horrible trochlea, and you're like, how do I create something out of that?
A chronic grade 4 just has nothing. It just has knobbly cartilage or fibrocartilage, and there's nothing going on at all. And that leads us as a really nice segue onto one of the other options, which is something a little bit new. Where we now have the ability to actually put in a groove, a replacement.
So we've got the patellar groove replacement. So that's been on the market, must be over 10 years, I think now.
Not new.
Yeah, must be. It's a big leap of faith to do that, because you can deal with a lot of these without doing it. And anytime you're putting in effectively a prosthesis, which if it fails, you can't do anything else with, that's something you'd have to be really cautious about making that decision. But the results with it are pretty good. We recognise that it's a ultra smooth titanium diamond coated implant, very low resistance, but we do see thinning of the patella. At the tip of it, it can catch on the patella sometimes. You can get some issues with that. There are a couple of newer ones that are just kind of coming onto the market just now. Very early clinical results, but I think they might make us think more keenly to use those. But there's definitely dogs where you and I both recognise some of them, they need it because you've got this horrible trochlea or it's flat, there's no bone. It's like, what else are we going to do?
So we're running close to the end of our time at this point. There's one more thing that we said we'd try and address, which is another debatable topic, or maybe not too debatable, but looking at luxation of patellas in growing animals. So
this is a common thing that I come across. The dog goes to their vet, 4 or 5 months of age, they recognise it's got a patella luxation, and do we leave it? Do we let it mature? Do we let it grow? And people are often worried about growth plates as well. Oh, we can't cut the tibia because there's a growth plate there. The problem is it's a very dynamic problem. And as the leg grows, if that patella's out of position as the leg grows, you're going to get some spectacular deformities. And I had a dog in the last year that we did one side very young, sort of 4.5 months. I was hoping to do the other side quickly. it didn't come back. And then when it did come back at a year of age, it was much worse than the first one had been.
Yeah.
And so I think the risks of going young are not outweighed by the sort of benefits of doing it. So yeah, so I if it's clinical,
yes,
then I would always recommend it. I mean, of course, that grade 1 luxation where the vet can feel it luxating in a vaccination, but the dog's never lame.
Yeah.
I'm not going to touch those.
No.
But if the dog's actually clinical, or if it's a grade 3, because sometimes they're not that clinical because the owner doesn't recognize it because it's symmetrical.
Yeah.
But if it's a grade 3 luxation and it's 4.5 months old, that dog is going to develop a deformity unless you deal with it. So I would definitely advise surgery at that age.
The dog wants to grow up with its patella in the groove. It's essentially, and if it doesn't, then that is a problem. It's going to increase via a bowstring effect, and the femur will be a virus and it'll be grade 4.
And the fact that the groove can't even develop, the patella's not there. It needs the patella to be there to actually get a groove. So.
And you just touched upon something else, and it's as always happens in these podcasts. That's a good point. Yeah. But actually, diagnosis of a grade 3 and 4 luxating patella, particularly 3, I think, but possibly both, are actually sometimes challenging.
Yeah.
And I mean, with 3s, I always almost think, can I positively feel the trochlear groove? It's like I'm not necessarily feeling patella because it's not necessarily unstable. It's just a lump somewhere in the vague vicinity of the knee. But actually, to actually feel the groove, you go, hang on, there's nothing in that groove all the way up. It's an easier way than actually trying to get the patella and going, is it unstable?
Yeah.
Have you got any other tips about diagnosis of those?
No, and I think the hardest ones are the grade 4s. Sometimes, because the grade 3, at least you can feel the patella moving. The grade 4, it's fixed medially. Yeah. And if you put your finger on the front, you can feel a groove. Great, it's luxated. But if it's a really nasty grade 4, it might not even have a groove. And I think, so if you've got a stifle that's quite thickened or just kind of doesn't look right, looks a bit twisted, and you're struggling with the anatomy, but you can't feel the patella luxating, be suspicious that might be a grade 4. Yeah.
And I think that's a really good point to end on, because it brings us full circle right back to the beginning of diagnosis. But it is always with an orthopaedic examination, there's an element of having to ask the question about sort of interrogating each joint, going, well, does it have a cruciate? Yes or no? Does it seem to be a patella problem? Yes or no? And I think unless, especially with grade 4, like you say, unless you're thinking about that, you're not necessarily, it's not in your wheelhouse, it's not necessarily in your thought process, and you might miss the diagnosis because of that. So you're actively thinking, is this a patella problem? And generically, if the joint feels absolutely abnormal and you have no real understanding what that is, it could well be a grade 4 luxating patella, and a radiograph should confirm that for you.
Yeah, absolutely.
Yeah. So I think we have pretty much run out of time on today.
I could talk forever about this, Chris.
Oh, absolutely.
Little geek zone. So.
You can geek out with a half-hour discussion, basically reduced to we don't really know. So,
but we know more than we used to.
Yes, we do. We do know
more than we used to.
We do. If you've got any questions, we'd love to hear from you. As always, I at this point always forget where the email address is, so it'll be on the screen somewhere. We'd like to hear from you. And as I said, strongly, if you've got any other suggestions of something you'd like us to talk about, even if it's just a very short question, we may do a session one time on questions that have been asked, and just get a group of people here, and we'll answer as many as we can. So with that, thanks for joining us again, and hope to see you next time, which will be number 11, and it might be about gastric dilatation of volvulus.
Excellent. I'll look forward to that.
No, you won't.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.